We want to tell you a little bit about Nina Sublette. She is an assistant professor at UT Memphis, and she's also a nurse practitioner and provides care to HIV-positive pregnant women and their infants. And her PhD research really focused around anxiety and depression in HIV-positive women. And she's really passionate around this subject and has given quite a few talks for the AETC over the years around this topic of HIV and pregnancy. And she just works in it every day, so she can really give us a good up-to-date perspective. And Nina, I'm going to hand it over to you, and thank you very much for being here.
Okay, thank you so much, Claire. Can you hear me okay?
We've got you.
Okay, perfect. Right off the bat, I can tell you that I have not spelled the word health correctly on my very first slide, so please don't panic. I can spell. Hopefully it'll be a little bit better throughout the rest of my slide set. But I wanted to start off just introducing myself. I'm Nina. I'm a nurse practitioner, and I have taken care of HIV-positive pregnant women since 1994, and I've learned so much during my career. I'm so grateful. The first case of perinatal HIV transmission was documented in 1982. It's a really long time ago, and I started nursing in 1990. So I feel very lucky that I've been almost able to follow a disease from the beginning. And it really has changed a lot, especially the treatment of pregnant women. So prior to 1994, the rate of maternal to child transmission of HIV ranged around 30% in developed countries, and it was always higher in the developing nations. But about 1 in 3 babies had a chance of being infected with HIV, or 1 in 4, some studies said. And we knew that some of the infants were at greater risk of transmission if their mother was sicker. So the more advanced CDC disease stage, the lower CD4 and higher viral loads, those babies had a higher risk of getting HIV from their mother. And although all the risk factors are known, it's impossible to predict which infants will be infected. Even though you can give a mom statistics, you can't really guarantee that her baby won't be infected. So we were very lucky here in Memphis to participate in the AIDS clinical trial group that gave AZT, which is one of the very first HIV medicines, versus placebo to pregnant women. It was a randomized double-blind study, so no one knew who was getting the placebo. And the study was actually stopped early during interim analysis. It was determined that the risk of transmission was greatly reduced by using the real drug, and it would be unethical to continue using a placebo. So it was unblinded, and all the women who were receiving placebo came in and were offered real drug. Since that very first study to today, you can bring the risk of maternal to child transmission of HIV down to less than 2% if all of these other things happen. If the mother is on a very effective multi-drug regimen, when C-section is used when appropriate and elective, if a mom does exclusive formula feeding with bottles, and then the elimination of pre-mastication for food for a child, which is really just the act of pre-chewing food. So a lot has changed since the early 80s, and now we use great treatment regimens that are much easier to tolerate. We use multi-classes, at least 3 drugs, usually 3 or 4 in one of our regimens, and our lab has gotten so much better. We can actually detect viral load now, and we can do genotype analysis to see which specific drugs are going to be effective in each woman's actual virus. And then we have also participated in pharmacokinetic studies, which give us great data, regarding the adequate levels of antiretrovirals in pregnancy. And then we use C-section when it's appropriate in antepartum care, and we continue the antepartum antiretrovirals during labor. So even though a lot has gotten better over time, some themes just remain the same. HIV is completely preventable. We know how people get it. The routes of transmission are known, but we have new patients in our clinic every week. The stigma related to HIV is still very much present. Women have sex for many reasons, and I always tell my patients that they are no different than any other woman in our OB clinic, because all of those women have also had exposure to sperm. And even though they might feel like they're walking around with HIV carved in their forehead, they don't look any different, and they will not be treated any differently than any other pregnant woman. No one wants to have HIV, and nobody wants to have a baby that's sick with HIV either. So we know that babies can get infected from their mothers at 3 different time points. They can be infected in utero while they're growing inside. Not as much transmission happens here. Probably about 20 to 25% of the transmission occurs antepartum. And this risk is greater if acute infection occurs during pregnancy, and there's a huge viral surge during that process. So the recommendation, according to the latest perinatal guidelines from the CDC, are to start antiretrovirals as soon as your pregnancy has been verified, and then change the regimen as needed if your genotype tells you that you might want to change it to a more appropriate regimen. Now, intrapartum, most of the infections, if they're going to happen, and remember they're less than 2% chance of the babies becoming infected, but if they were, the majority of the transmission does happen during labor and delivery, and that's around 80% of the transmission. So while a woman is in labor or we're planning for her delivery, we implement all kinds of things like the use of IV AZT when indicated if her viral load is higher, and then we continue her antiretrovirals during the labor process, which is something you really need to stress because a lot of women are immediately made NPO on admission. And then the elimination of any kind of invasive device like scalp electrodes during labor. And then for postpartum prevention, we do a great job of telling our patients about bottle feeding and the risk of transmission with breastfeeding, but the risk of transmitting with the act of pre-chewing food is something that is kind of new to us, and we never even thought to ask about it until we had a documented case here in Memphis, and I'll talk about that in a minute. So I work in an OB clinic, and we are part of a high-risk clinic of maternal fetal medicine, and I was going to tell you just a little bit about what we do for our antepartum care and how we go about the process. When we very first get a patient, one of the first things you need to do is actually verify their infection. We've had several patients referred to us that were truly not infected but were told that they were. Either they had a false positive ELISA or their doctor just gave them the wrong information. So we always verify their infection before we do anything. We obtain baseline labs, and I'll go over those in just a minute. And we also determine who have they told about their HIV status. It's always a good idea to ask people in the room to leave while you're doing your intake, because you never know exactly what they've told other people in the room, and nobody wants to, pretend like they can't talk about something because it's a big red flag. So it's my practice now just to ask everybody to leave while you have that initial discussion. And if they haven't told anybody, that's just a process of doing disclosure counseling with the patient. They don't have to do it immediately, and it's often something that, we'll talk about throughout the pregnancy because it's really hard for some women to do. And then we have the discussion about maternal to child transmission of HIV and give them any statistics so that they have an incentive to come back. A lot of times they're really overwhelmed with all the information that we have and all the statistics that we throw out there. So if you can just give them some hope with statistics and get them to come back, that's one of the best roads to a healthy baby. And then I always tell my patients that we have a collaborative relationship. It's a team approach. It's my job to tell them what I know about HIV and how to prevent HIV transmission to babies, but it doesn't work if they don't take their medicine. And we established pretty early on the need to be honest and talk about fears so that a patient can know what to expect throughout the pregnancy. And then we talk about our goals, and I always say that pregnancy is a huge incentive, and so our patients tend to be a little bit more compliant with their regular appointments than I think they are when they are not pregnant. Our baseline labs contain just a whole list of things, and I'm sure it varies from clinic to clinic. This is just what we get on all of our new patients. We get a CD4 and viral load and a genotype. And remember, to get the genotype, you have to have detectable virus, a CBC with diff and platelets, a CMP. We get all the hepatitis studies and a renal assessment. And in order to do a proper calculation of creatinine clearance, you really need to use the weight of the patient that was obtained in the clinic the day that their blood was drawn. The varicella, CMV, IgG, and IgM, and then we do an HLA-B 5701 to see if they could have the mutation to have a hypersensitivity to abacavir. When you choose an antiretroviral treatment for anybody, really, but especially a pregnant woman, you want to make sure that it's a great regimen. Your first shot's going to be a really important shot, and you want it to be a long-lasting option. So you want it to be durable, you want the patient to be able to tolerate it, and you want it to be as simple as possible. You want to be sure that your patient is going to be able to take the medicine, because like I said earlier, it doesn't really help if it's just in the medicine bottle in their bathroom or in their purse. So I think disclosure has a lot to do with adherence at this point, because people become suspicious when they see you taking medicine. A lot of my patients will take their medicine out of the bottles and put it in a Tylenol bottle, and that, could also have some terrible ramifications. So these are things you just want to talk about with your patient to be sure that they're going to be able to take the medicine. And you want to have a plan for sequencing their medicine, especially if this is going to be their very first one. So when do you start it? Well, the newest perinatal guidelines recommend that you start antiretrovirals as soon as the pregnancy is verified. But this will vary according to when a patient even seeks prenatal care or gets consultation from infectious disease. If a patient is less than 8 weeks pregnant, it's not recommended to begin a bacavir treatment, Cystiva, efavirenz treatment during that time period. If they were already on a Cystiva-containing regimen like ATRIPLA and they became pregnant, then they can stay on it and not stop. The danger of stopping is having a viral surge, which could increase the risk of transmission to the baby. There used to be some teratogenicity concerns surrounding Cystiva, but a lot of those were based on research in macaques and not really seen in humans, because most of the time when people found out they were pregnant, it was after the first trimester, and so we were stopping it even though all the organs had already been formed. So it's earlier the better in women who have low CD4 counts, but again, the guidelines say to recommend starting as quickly as possible. And then what if you get a woman who's like 36 weeks? Is it too late to start medicine? It's really never too late. You just need to do a really good assessment with their adherence and see if they're going to take the medicine at all. A lot of times people, if they present this late in pregnancy, may opt to skip the ANTEPARTUM time period and just get treated intrapartum and then dose the baby. And, you have to respect a patient's wishes on that and make sure that they understand the risks and benefits. You can see a complete viral suppression in a matter of weeks. So the regimens do work really well and they act really quickly. So when you're starting HIV treatment in women who are pregnant and naive to treatment, you can always go to the NIH guidelines. You can Google it. Go to AIDSinfo.org is the easiest way, I think, to access information. The guidelines are frequently updated, so there's always a little bit of caveat with caution there, because a lot of times you'll remember what you've been doing for years and not think to look at the recent guidelines. So they are updated frequently, and I would recommend that you check them often. Tables are your friends. Go to the table of contents and go to the tables, and that'll really tell you exactly where to get started if you're in a hurry. You need to know what kind of pregnancy category the antiretroviral has, if there's any kind of interactions with any of the other concomitant medicines that they might be on, and you need to know your patient's other risk factors. So what are you going to start them on? When you have a list of medicines to start a patient on, it's almost like a menu, and you choose like an entree and a couple of sides. So you're going to choose a backbone regimen and then a drug from another class, and all of these other things are going to play into your selection of a regimen. Do they have other comorbid conditions like hypertension or renal insufficiency? Because a fixed dose combination is difficult to alter, and so you can't provide a lower dose. The convenience of the regimen, the adherence potential, and please warn a patient about possible side effects so they can be expecting them and know what to do in order to alleviate them instead of just stopping abruptly. We do resistance testing, and usually we can get that back in less than 2 weeks so that we can choose a regimen. Sometimes you can start a patient early, just right away, and then wait until their genotype comes back and then change the regimen if necessary. And if a drug has food requirements or needs food as a boosting agent, you really do need to assess just the patient's accessibility to food. Do they have it? Do they have a refrigerator? Do they have crazy work hours when they're not allowed to eat, regular meals throughout the day? So you want to be sure that they're going to have access to food if it's a requirement for their medicine. And then gestational aid's always important if you're looking to avoid teratogenicity with Sativa. So like I said, clearly I'm hungry. There's a menu of options, and you just need to use the appropriate combinations. So just because drugs are available, like I remember D4T was so well tolerated and we loved it, it's not the best choice for women or any patient anymore. And you need to be sure you consult the most up-to-date guidelines. And then think, can this patient be successful on this regimen? Because you want it to last as long as possible. And the guidelines you use for pregnant women are generally the same recommendations that are used in non-pregnant adults. A lot of the things vary according to pregnancy, especially pharmacokinetic data. I'll get into that in just a minute. So when you read the guidelines, there's going to be a list of regimens that are preferred and a list of regimens that are alternative. And you have to remember that guidelines are just guidelines. They're based on research studies. They have a lot of history behind them, but they're not laws. So it's going to be the clinician's responsibility to choose the best regimen for that patient. And one of the preferred regimens is going to be a backbone plus. So a backbone is what we refer to as a 2-drug combination, a nucleoside reverse transcriptase inhibitor. And we have a couple of fixed-dose combinations of those, with AZT and 3-TC being combined into abacavir, and then FTC and tenofovir combined into Truvada, and then tenofovir 3-TC and abacavir 3-TC combined as Absicom. So you're going to use one of these backbones and then choose a drug from another class. Historically, we used to use a whole lot of Combivir and saw a lot of AZT-related anemia, which was made even worse during pregnancy. And I think Truvada is probably our backbone of choice now, just in our clinic. So you're going to use backbone plus a preferred regimen list the protease inhibitors. Protease inhibitors are more pills, but they're very potent regimens. And the protease that wins the label for preferred drug regimen in pregnancy is going to be darunavir with a Norvir boost. You cannot use once-daily dosing of darunavir in pregnancy because the pharmacokinetics aren't there to support it. So it's going to be twice-daily dosing. There is less experience with darunavir than there is Kaletra, but the side effects aren't as bad. And then the other protease inhibitor that gets the green flag for a preferred regimen is atazanavir with a Norvir boost. And when you dose atazanavir during pregnancy, it's 300 milligrams of atazanavir 100 milligrams of Norvir, but the dose needs to be increased at the end of the second trimester to 400 milligrams of atazanavir with 100 milligrams of Norvir. And you need to warn the patients about the side effects that they're going to see with the atazanavir, especially scleral icterus and jaundice, because that might be offensive and it's a little troubling when you look in the mirror. Atazanavir is also a very lipid-friendly option. So these are the preferred PIs. And then if you were going to use a non-nuke, you would use a backbone, one of the first slides I showed you, of a combination of 2 nukes plus non-nuke. So this is where things get very exciting and a little scary, because efavirenz is a drug that we used to always stop when people became pregnant, and now it's made the list of a preferred regimen in pregnancy. And a lot of the fear was related to the teratogenicity. So it's still not recommended to begin efavirenz early in a pregnancy, so you can wait until after a patient's 8 weeks gestation, which most patients don't know that they're pregnant until after at least 8 weeks in my clinic. Then you can use a fixed dose combination of atripla, which is 1 pill once a day, and that's really easy for patients to tolerate. You do need to give them education about side effects, especially people with a history of any kind of mental illness or depression, because the dreams can be a little frightening sometimes, but they will get better over time. You can use a preferred regimen of a backbone plus an integrase inhibitor. The integrase inhibitor, raltegravir, is very well tolerated in pregnancy, but it is twice daily dosing. So if someone's not going to be able to be compliant with a twice daily regimen, it might not be the option you'd want to choose. Then the regimens go on to be alternative regimens. So they're not contraindicated in pregnancy, they're just not on the preferred list. So one of the alternative regimens would be a backbone plus a protease inhibitor of lopinavir with a Norvir boost, and that is a fixed dose combination known as Kaletra. Kaletra was used for a long time in pregnancy. It is not especially well tolerated. There's a lot of GI side effects. The pills are big, the smell of the pills is a little offensive, and when you combine nausea and vomiting just related to pregnancy with the stinky drug, it's not a great combination. And this is a drug that needs to be increased during the end of the second trimester because of pharmacokinetic reasons. So you would increase from 2 pills twice daily to 3 pills twice daily, which is a fairly large pill burden. Another alternative regimen would be a backbone plus non-nuke. Here it's nevirapine or Viramune. And this is only going to be used in women who have baseline CD4s of greater than 250. In sicker women, the risk of hepatotoxicity is greater if their CD4 is lower. You start nevirapine out with a lead-in dose of once daily dosing, 200 milligrams a day times 14 days. Bring the patient back in 2 weeks, check their liver functions and side effects before you increase it to twice daily dosing. And then there's a thought that you might just want to give them 14 pills instead of giving them a full prescription for the 30, just to make sure that they come back for that assessment of their liver functions. So there's a lot of excitement about the once daily pill regimens, and for anybody that has looked at a regimen that might contain 8 or 10 pills a day, when you think about a fixed dose combination of just 1 pill once a day, it's very exciting. But they're not always the best choice for a particular individual. They have been approved for adults, but the pharmacokinetic data is really insufficient in pregnancy. There's limited time on the market, so the safety data is also limited in pregnancy. And even though it's kind of the hot new thing to try and everybody wants a 1 pill once a day option, it might not be the best possible option for that particular patient. So some of the newer drugs that have insufficient data but are used a lot, and if a woman becomes pregnant while on these medicines, we leave them on it. So one of them we're seeing a lot of now is Complera. It's a fixed-dose combination of rilpivirine and Truvada. It's great because it's a pregnancy category B, but it's not recommended if you have a pretreatment viral load of greater than 100,000 copies or a CD4 count that's less than 200. And it's not as forgiving with missed doses as some of the other regimens are. And be careful if a patient also has Hep B co-infection, and you are not supposed to use it with PPIs, and there's limited data in pregnancy. Now, we have a lot of patients on it, and we start a lot of patients on it, but there is a caveat to that. Another fixed-dose combination is going to be Stribild. It's a pregnancy category B. There is a risk of lactic acidosis, which is more common in women and overweight patients, which is, of course, all of my patients are pregnant, but the majority of them are also overweight. And there is a food requirement with Stribild, so if a patient doesn't have access to food, that's not going to be a good option for them. And then no antacids, either 2 hours before or 2 hours after dosing of Stribild. And a lot of my patients are on antacids just because they're pregnant and they have heartburn and they chew them all day long. So you want to be sure that you're educating your patient about all of the potential interactions and side effects of regimens. So when you have a pregnant woman who is HIV positive and she has a history of antiretroviral therapy, it's a little more complicated to either initiate antiretrovirals for her or just assume her care. You're going to want to be sure that she's on a regimen that's working. ACOG guidelines for a long time said that a viral load less than 1,000 copies was going to be safe for delivery. Well, in the infectious disease world, any viral replication is dangerous because you get the inflammatory damage done even with a very low level of viremia. So we want all of our viral loads to be as undetectable as possible. And remember that they're guidelines, they're not laws, but do read them when you need to and consult an infectious disease provider if you have to. And I don't know about practices of co-managing HIV-positive patients in an OB clinic, or if you're going to also want them to see their infectious disease provider during their pregnancy. I think communication is really key here because so many providers automatically just stop all medicines when they find out that one of their patients is pregnant. And that is something you don't want to do in HIV infection because you don't want the patient to have a viral surge or rebound. Remember that the guidelines are updated frequently, and you just need to be familiar with the tables so you can find them when you need to. And it's almost like becoming a private investigator or a detective. We have to find out how you're going to really start this investigation of which medicines they've been on in the past in order to choose the regimen that's going to be best for them now. And it really can be almost like a real detective work or an investigation. It can be time-consuming, and I know time is something that's very precious in everybody's practice. It's best to get patients' medical records if they remember who their infectious disease provider was. You can use their reports of their date of diagnosis, if they can remember what their initial CD4 and viral load looked like when they were diagnosed, and then the start and stop dates of their antiretroviral regimens. And why were they changed? Were they changed because of side effects, or did they develop resistance to that regimen? And find out the reasons, why the regimens were stopped and started. If you can have a history of genotypes to look at, that's even better so that you can determine potential mutations, because you won't see a lot of them unless the virus is under active drug pressure. So if they come to you and they haven't been taking their medicine for a while, you're not going to see all of the mutations, although the new genotypes are much better at doing that. And after we start our medicines, we bring our patients back in 2 weeks just to check for multiple things, but especially toxicity. One of the first things you need to make sure is that they even got the medicine. Just because you prescribed it and sent it to the pharmacy doesn't mean that the patient's even taking it. And that's something that you want to verify before much earlier than a 4-week return appointment. So you want to be sure that they picked it up, that they're taking it as prescribed, and then we do labs for toxicity. We usually do a CBC with DIF, and a CMP. You need to follow up labs just to watch for immune reconstitution. And we used to check our CD4s monthly when we did our viral loads, but now it's recommended that you can space that out to every 3 months after initiation of HAART. And that's also true in pregnancy. But if a woman is kind of hovering around a threshold for opportunistic infection prophylaxis, you might want to check it a little more frequently than every 3 months. We check our viral loads pretty quickly, sometimes 2 weeks when we check their toxicity labs, or 4 weeks after initiation. And then we check it monthly until they're undetectable. And you should be able to get a patient to undetectable in approximately 12 weeks, but that seems like a long time. We've seen it happen really quickly. So when do you determine if your regimen isn't working? And in pregnancy, your deadline is just a little more finite because you want to get them to undetectable as quickly as possible, especially before the baby is born. And you want to have the last viral load drawn between 34 and 36 weeks gestation so that you can plan appropriately for delivery for a vaginal versus C-section. And luckily, you have other tests that are due around the same time in pregnancy, like a group B strep screen and hepatitis and RPR, so we just get all those at the same time. It's a good reminder. You might need to repeat your genotype if a patient still has detectable virus after they've been on a regimen and they do report compliance. Most likely the detectable virus is present because of noncompliance, but they could be resistant to it, so you can repeat the genotype. And then protease inhibitors have kind of a bad rap with glucose. So if a woman has been on a protease inhibitor for a long period of time, you might want to do an earlier glucola instead of waiting until 24 weeks gestation. And then still repeat one at 24 to 28 weeks. And amniocentesis used to be something that was completely contraindicated in perinatal HIV care, and there have been some changes in the guidelines for this, and I just really can't believe that's ever even happened, but there have been no perinatal transmissions reported after an amnio if a woman had full virologic suppression on HAART. Now, it's not an amnio just to check for fetal lung maturity to plan the C-section. It would be an amnio that would be indicated because of other problems, especially genetic abnormalities or something that came back on their labs. So there's always a small risk of transmission, and you can't rule it out even if they are undetectable on antiretrovirals. So it's something you're going to want to really weigh carefully and do a great risk-benefit analysis when you're talking about amnio with your patient. Additional considerations to remember when you're treating HIV-positive women are just basic HIV education. Just because a woman has been HIV positive for a while doesn't mean she understands what she needs to know about her health or her disease or how the medicines work or why we're even prescribing them. So, you know, always kind of start from the beginning. And I always tell people, you've probably heard this a million times, but I want you to ask me any questions if you have any questions or concerns, because a lot of times people really don't know, and they will nod their head or tell you they understand when they really don't, for a variety of reasons. But number one, for us, it's they don't want to disappoint their provider, or they've been there so long they don't want to get into it all over again. But I think if a patient understands the reasons why you're prescribing medicines and doing the things you are in their care, then you'll have similar goals. And disclosure counseling is something that is usually ongoing during a pregnancy. We will continue this throughout the pregnancy, and I've always learned that if you harp on something long enough, all the patient has to do is tell you that they've disclosed. It doesn't really mean that they've done it. It just means they want you to stop talking about it. So again, honesty and good communication is going to be important between the patient and all providers, not just the physician, but social workers or anybody else that's working with the patient, because the patient needs to understand the importance of why we talk about disclosure counseling. And then safe sex counseling. A woman is there because she got pregnant. She clearly was at risk for pregnancy, so she wasn't probably not using a barrier contraceptive. And there's a lot of confusion with providers and patients about the use of condoms in concordant couples. So if both the man and the woman are HIV positive, they still need to use condoms to prevent the transmission of resistant virus to one another. And then if it's a discordant couple, you need to protect the partner from the infected partner so that they don't get infected. And there's a lot of, talk with PrEP right now to do that. So safe sex counseling is something that continues throughout pregnancy. And for care of HIV-positive pregnant women, it's really important that we have an early ultrasound to get an accurate determination of gestational age, especially because when we do elective C-sections, we do them at 38 weeks. And a lot of other of the maternal indications for C-section are at 39 weeks. So you want to be sure that you've got an early ultrasound for good dating so that when you perform the elective C-section, the baby can have adequate lung maturity. So when you have a pregnant woman who also has HIV, does this really make her an instance of a high-risk pregnancy? Is this something that needs to be cared for by either a maternal fetal physician or somebody with a lot of experience in HIV? And I think that that varies according to just where you are and your individual knowledge level. But there are things that people need to know about pregnancy in general that make it different than treating a non-pregnant adult. There are so many physiological changes during pregnancy. Drug absorption, volume distribution changes during pregnancy, so you need to be aware of the pharmacokinetic parameters for the antiretrovirals that you're prescribing. And then there are just complications of pregnancy that you need to monitor and be sure that a patient is not developing things like either fatty liver disease or preeclampsia. You want to be sure you can use drugs that cross the placenta and know your pharmacokinetic recommendations. And then pregnancy in and of itself is an immunosuppressive state. So not only are you immunosuppressed from HIV, you're also immunosuppressed from pregnancy. And non-HIV positive women also have lower CD4 counts in pregnancy when they are HIV negative. I don't know if I said that correctly. HIV negative women have lower CD4 counts in pregnancy, just like HIV positive women. You need to start planning your delivery. You can start talking about it at the very first visit. And I know that making a plan doesn't carve anything in stone and things change very quickly, but it's best to have a plan and then monitor the patient throughout the pregnancy and change it as needed. But a pregnancy history is really important here. You want to determine if she's had a prior C-section and is she going to be a candidate for a VBAC if you can get her to undetectable. And then you want to, if you're going to have an elective C-section, the indication is that we do it at 39 weeks. You want to do it at that time period and not 39 weeks because you want to be sure that you have done the C-section before the rupture of membranes and before the onset of labor. And there used to be some worry about rupture of membranes. If a woman's membranes were ruptured for greater than 4 hours, they were rushed to the to the operating room to have a C-section. But the statistical benefit of a C-section is kind of lost if they've already ruptured. The horse is out of the barn. You're not going to have any more protection to do that. But there is benefit of doing a C-section for other reasons if they've been ruptured for a long time, like infection. If their last viral load prior to delivery is greater than 1,000 copies, or if they have an unknown viral load, that's going to be somebody you're going to want to do an elective C-section with for an HIV indication. Or if you have a patient that's newly diagnosed in pregnancy or labor and delivery, So they show up in labor and delivery and either they've had no prenatal care or in Shelby County we do a repeat HIV test in the 3rd trimester. And if you have an unknown repeat test and that test is done in labor and delivery and it's positive, that could be an indication for an elective C-section. I would use caution here, though. We have had some false positive screening tests in labor and delivery, and the women have, I don't remember if any of them had actually had C-sections, but they were told, that their HIV status was positive. You want to continue their oral antiretrovirals during the labor process. And sometimes that's difficult to get anesthesia to agree with you on, but we just give them with small sips of water. You want to keep their viral load suppressed even during this labor process. And then the guidelines changed. We used to give IV AZT to all pregnant women with HIV. They changed in March of 2014. So it's recommended now only in patients with the viral load greater than 1,000 copies. And ideally, you should weigh the patient when they're admitted because it is a weight-based regimen, and it's 2 milligrams per kilogram. I'm sorry, that's reversed. 2 milligrams per kilogram over an hour, and then 1 milligram per kilogram maintenance per hour until delivery. It's best to have a total of 3 hours. So an accurate weight is important because I know I always underreport my weight. So I think that if you just weigh a patient routinely on admission, that's probably best. If they're ruptured less than 37 weeks, you're going to want to give steroids. And an amnio is not recommended just to test for fetal lung maturity. So even though you can bring the risk of transmission down from 30% down to less than 2%, there have been cases of maternal to child transmission with very low levels of viremia, which is a little bit scary because if you have a patient that's really concerned and undetectable and very compliant with their regimen, you want to be able to say that you guarantee that their baby will be HIV negative, but there's really no way to offer any kind of guarantees. But as long as you treat women during pregnancy, and then the appropriate use of antiretrovirals in labor and delivery, the elimination of any kind of invasive procedures during labor and delivery like the use of scalp electrodes and the use of a scheduled elective C-section, and then a treatment to the infant with oral AZT or a combination regimen if indicated, you can really reduce the chances of the baby becoming infected. It's important to remember that C-sections aren't minor procedures. They are major surgeries, and there's always a risk for maternal complication. Research has shown that HIV-positive women have increased rates of post-op complications. Most of them are related to infection. And then, there's always a case where you're going to be planning for a vaginal delivery, and you're a little, surprised that the patient, for obstetric reasons, needs to have an urgent C-section, but always keep the patient in mind. We bring all of our patients back for a 2-week postpartum visit. So a lot of doctors only do that if they have a C-section to check the incision, but we want to be sure that everything is going okay with mom and baby. How is the baby feeding? Are you using, formula with bottles? Are you mixing the formula appropriately? Are you giving the baby the AZT or the antiretrovirals that have been prescribed? Has the baby been to its very first infectious disease clinic appointment? All of these things, you need to be aware of by 2 weeks. And we should also screen for postpartum depression at the 2-week follow-up visit. I think we do a poor job of screening everyone for postpartum depression. It's probably good to implement that just in your regular practice. And then inquire about support. Who's helping you take care of this baby? When you have a newborn at home that needs to eat every 2 hours and give medicine twice a day, it's kind of hard to take care of yourself as well. And a mom's going to have to continue her care. And women historically care about others more than they care about themselves. So you want to have great support system at home and somebody helping her with the baby. And then it gets a little complicated if people in the home don't know about the HIV status and they feel a little hesitant about giving the medicine in front of other people, or if their family is asking them why they aren't breastfeeding, it's best for the baby. It can be a little tricky. Make sure the baby has a follow-up appointment in the infectious disease clinic. Then the continuation of antiretrovirals. Things have really changed over the years, and now it's recommended that people continue on antiretrovirals. It's always best to have good communication with your patient. If they're overwhelmed and they are not adherent, it's better to discontinue all medicines than to take them as needed or when they remember, and if you can stop them for just a short time period to resume later, that might be best for that patient. You need to plan for their infectious disease follow-up. Where are they going to go for their care? Will that doctor even take their insurance and help them make that very first appointment? Pregnancy, NKS, that's just my initials. I always say once the baby is out, you've lost your incentives. The carrot's gone. That perfect compliance of all their return appointments isn't always going to work in a non-pregnant person because HIV doesn't hurt. People forget that they don't have it. People are in denial of their disease status. So you want to be sure that you hook them up with a good infectious disease doctor post-delivery. And hopefully you've talked about postpartum birth control during the pregnancy, but it's something that is of particular concern with HIV-positive women because of pharmacokinetic reasons of birth control options competing for the same sites as antiretrovirals, which make them less potent. And then future pregnancy planning. Just because you have HIV doesn't mean that you're not going to have other children, and you want to talk to them about doing that in a timely fashion. And, of course, safe sex counseling. You want to be sure that they are giving formula with bottles, and in this country we have WIC, so that even the poorest of poor patients can get formula for their babies. And if you have a patient that is kind of adamant about breastfeeding, you want to be sure that you just educate them to the best of your ability about the transmission rate. And there is documentation of transmission from mom to baby with breastfeeding. But if you think she's adamant about it, then she needs to be an exclusive breastfeeder and not switch back and forth from breast to formula because it can cause GI bleeding and increase the risk of transmission to the infant. But in developing countries where there has to be breastfeeding, that's what's recommended. And then you need to provide education for the patient about pre-mastication. That's the act of just pre-chewing food before you give it to your child. And this was something that was documented in the Journal of Pediatrics in August 2009, and the primary author is Aditya Gar, a pediatrician in the infectious disease department at St. Jude. This was a transmitted case of HIV from mom to baby. The baby had already been tested in the HIV screening clinic, was born because he or she was born to an HIV-positive woman and had tested negative, but then was admitted to the General Pediatric Hospital for an opportunistic infection, was retested, and it was determined that the baby was HIV positive at that time period. And upon extensive investigation, the route of transmission for this baby was that the mother, who had very high levels of virus, was non-compliant or poorly adherent to her regimen and had grossly poor dentition and bleeding gums, had chewed food and then given it to her baby. So you want to be sure that you've told the woman, the patient, that her baby is also going to be recommended to have HIV medicine, even though their HIV status is going to be unknown at first. A lot of times I think, I know I forget that because I'm so focused on the pregnancy, but you need to tell them that they're going to also be giving their baby medicine and the baby's going to have follow-up appointments, and tell them you won't know at first if the baby's infected or not. You need to use serial testing, and you need to be sure that you are testing the baby appropriately, because if you just use a standard antibody test, you're just really indirectly testing the mother again. So the infants need to be tested preferably by infectious disease specialists. So even though things have gotten so much better over time and the risk of transmission has been greatly reduced, there are still new perinatal infections every year in this country. And so why is that happening? I think lack of prenatal care or lack of screening and actual testing is probably one of the main problems. And then suboptimal HIV management. They were getting the wrong regimen or not an appropriate dose. And then how adherent were they to that regimen, both the mom and the baby. So even though we have all of this knowledge and can do so many great things, there are still positive babies in this country.
So we have a couple people that have their hands up, so we're going to start there. Again, just reminder to everybody, you can type a question to us using the Q&A box, and you can also click on the little hand icon. That'll raise the hand next to your name, and we will unmute your mic. So we're going to start there. Christine has her hand up. Christine, are you still on the line? Would you like to ask a question?
I am. Back in the beginning, she said something about a viral surge, and I don't know, I've never heard that before, and what would cause a viral surge? Thanks.
That is a great question, and I always describe to patients that, well, first of all, if a patient is newly diagnosed or newly infected during pregnancy, there is a huge active viral replication. So you're going to have a really high viral load right after infection, and that will settle down into a set point. So if a patient is infected during pregnancy and there's that rapid viral surge, so there is rapid work of the virus to make millions of copies of itself as fast as possible before it settles down to that set point, that baby is going to be at greater risk for HIV transmission. And what became so important for this, especially in Memphis and Shelby County, was the fact that we had several babies that were born, I'm not quite sure of the numbers, but they were born to women who had been tested in pregnancy and they were HIV negative. But for some reason it took providers a really long time to figure out that women might just have sex after that first prenatal appointment. So the risk of acquiring an infection continues during pregnancy, not just because you've had the test done, it's not a safety mechanism. So that's why we do third trimester rescreening and, if unknown, repeat in labor and delivery. And then you can also have a viral surge if you stop antiretrovirals in pregnancy. So the virus will work really hard to make copies of itself during that time point, and you'll have an increase in the viral burden during that time. I call that a viral surge. You want to avoid that in pregnancy.
Thank you, Nina. And we have a couple of questions actually around disclosure, and people are asking if you can kind of elaborate on how you communicate with the patient the importance of disclosure and how that relates to HIV and pregnancy. I mean, trying to disclose to their families and trying to make people understand that piece of it.
Yeah, and I have been on, you know, many sides of this fence. So when a patient is newly diagnosed, I think just over time, caring for HIV-positive women over time, I've learned that no matter who they tell, if they tell one person, and I don't think the provider counts, if they tell one person in their circle, their friends that they can trust, they just do better. They have support, they don't feel as bad, they're not as filled with such shame. And anytime you try to keep a secret or hide something, you know how it just kind of eats you up from the inside. So we always encourage disclosure, not only just for a more positive outcome, but also for transmission reasons. So if a woman doesn't feel comfortable disclosing to the man that she's having sex with that she has HIV, you need to figure out why. You know, are there safety concerns? What's going on there? And again, it's nothing that you're going to do for the patient. It's not anything that you require. I think counseling is so important here, and education. And because, you know, I've done it. I've harped and said you need to tell your partner, especially, you know, if the husband or partner is coming to the appointments with them and they don't know, it's very stressful. But if you just harp on it for so long, all a patient has to do is tell you they told, and you'll quit bothering them about it. So you just want to be sure that you're educating the patient and giving them all of the information that they need to encourage disclosure.
Right. And then we're going to get into a couple of the med questions. So can you just clarify, darunavir was twice a day? Is that what you said?
Yes, there is once daily darunavir dosing, but it's not recommended in pregnancy because the pharmacokinetic levels don't get high enough.
And people are kind of asking, trying to figure out how to kind of implement things at their clinics. So what kind of processes do you have in place for patients that don't have access to food and good nutrition but need a med that requires meals?
You know, I'm very lucky that, right. I'm very lucky to work with great staff. So I work with a multidisciplinary team. You know, we have a nurse on our hall. We have a WIC office in our clinic. And then I also work with social workers who can always get more information from a patient than I can. So we use all of those things. It takes a long time to get a good history on a new patient.
Okay. And then how about patients that are choosing a midwife over an OB or a traditional delivery? How do you handle that?
We have historically not had that in Memphis. We did not have a lot of practicing midwives, but the practice where I work has just hired 5. So these are going to be hospital midwives that will deliver in a hospital. They're advanced practice nurses. So I don't really know about the use of lay midwives or people delivering at home. We have had people that accidentally delivered at home or at a grocery store or at their place of employment, and that's just one of those, you know, unplanned things that happen to pregnant women. But if a woman is really wanting to have a home birth, you know, you just need to offer her education, and you don't get to decide for people, and you don't get to tell them what to do. You need to have them make an informed decision based on the information that you provide to them. So you want to be sure it's a safe environment. They might need IV medicine that a home birth wouldn't be able to provide. You want to have a controlled environment. So you just want to be sure you arm a patient with all the information.
Okay. And then we do have a couple of people asking if the slides will be available. Nina, you can let us know if you're comfortable with that, and we'll create a PDF and we'll put them up on our website at the end.
I just want to reference it at the end because most of my stuff comes from AIDS Info, which is the NIH website, and I did say that in there in the slides, but that's really the main site I would like people to go to. And if I could correct the word health on the first slide.
Sure, we can do that.
Then you can have them.
Okay, great. And then we do have a question about the effects of the meds on the fetus. I know there's been some research with babies that were born and trying to figure out what their rates of if it affects their rate of development at all, having been on HIV meds. Do you have any comments you can make along those lines?
I can. I'm not a pediatric expert, but I am lucky enough to work with them. So if any are on the call, they can text me now if I say something incorrect. But we do have long-term follow-up studies that we do at St. Jude as part of a research network. So we enroll babies that are born to HIV-positive women who are actually HIV negative, but they were exposed to antiretrovirals during pregnancy. So the study is called SMART, and it's S-M-A-R-T-T, and it's looking for toxicity related to maternal use of antiretrovirals. So I believe that there were some initial concerns about some transient anemia in infants that were exposed to the oral AZT. That was corrected with formula. I don't think any babies needed any blood transfusions because of the AZT. But I think there are some concerns about growth and development, especially height, that the height may be decreased in babies that were exposed to antiretrovirals from their mother. So, you know, again, it's a risk-benefit thing. You want to be a little bit short or, you know, have HIV from your mom. So it's one of those things that long-term follow-up studies are so difficult to conduct but so important to get this kind of data. And the people at St. Jude could really answer that a lot better than I could.
Great. And our last question we have a case manager asking if there's any postpartum screening that you could suggest a social worker or a case manager do. Is there any type of tools available that you know?
Depression?
Right.
Okay. Yes. The two questionnaires that I am the most familiar with, just from my own personal use, are, and they're both free, are the CESD. It's the Center for Epidemiological Studies Depression Screen, CESD. And it's free. Just Google it, CES-D. And it's I believe that's a 10-question questionnaire, and you can do it really quickly in the clinic. And there is a legend that tells you, if a patient has a certain score, they need more further screening. And then the other one is the Edinburgh Postpartum Depression Scale. That is the EPDS. It's also free, and it's very short. It is from Edinburgh, so they do ask things a little bit differently. I think a term that's used, I can't remember exactly what it is, but maybe people in the South might not be as familiar with it. And it's something about depression. But we use that a lot, and that's actually the one that's attached to our medical record. So if you, our new fancy electronic medical record, so if you are suspicious or want to do some extra screening, you can just print that off and give it to the patient. Both of those are free and very easy to use.
Great. Well, Nina, thank you so much for your information today. We really appreciate you doing this talk for us.
And thank you.
No problem. And we'd like to let everybody know that we will see you next week for Webcast Wednesday, and just keep looking for advertisements. Thank you for tuning in.